So welcome everyone. Good morning, good afternoon, good evening, depending on where you're calling in from. I wanted to thank you all for joining us for today's webinar on building global health structures accountable to communities they serve. Today's webinar will be recorded, so you'll get a recording and summary of it to your email afterwards, so you can revisit it or forward it to people who missed the conversation. We will also be using the Q&A function today. So that should be at the bottom. Yeah, that should be at the bottom of your Zoom screen. So throughout the webinar, as you have questions for particular panelists or in general, please drop those in there. And with further ado, I will pass things off to Dr. Shriram Shamasunder to introduce us to our panelists.
Thanks, Kia. Good morning, good afternoon, good evening. Thank you for being here. My name is Shriram Shamasunder. I'm a physician and one of the co-founders of HEAL Initiative at UCSF, and it is a real honor to facilitate this conversation. I wanted to say at the outset what the hour is and what it isn't. This is not a panel about a crisis happening somewhere else. This is a panel about a rupture that all of us in this room are living through in real time. Aid structures are fracturing. Bilateral agreements are being rewritten. PEPFAR, a program that has kept more than 25 million people alive, is being pulled apart in front of us. USAID has been dismantled, and the communities that have been bearing the heaviest burden for decades are, once again, the ones with the least say in what comes next. The Global South and Africa in particular have been living some version of this story for a long time. Centuries of colonial extraction gave way to decades of structural adjustment and odious debt, in which sovereign governments were told that the price of legitimacy was to dismantle the very public systems, health, education, food sovereignty, that they had finally been independent long enough to begin building. Today, more than 30 African countries are spending a larger share of their national budgets on servicing that debt than they spend on health. The United States and Europe are on net financial extractors from the Global South, receiving more in debt service from the developing world each year than they pay out in development assistance. And most of what does get counted as aid never actually reaches the recipient country. Studies have repeatedly shown that the majority of U.S. overseas development assistance stays inside the U.S. economy, in contractors, consultants, supply chains headquartered in the global north. The story today is not that a generous system collapsed. The story is that the system was already extractive, was already lying about itself, and now also stopped paying out. So we could spend this hour cataloging what is being lost. There's a version of this conversation that is only grief, and that grief is warranted. But the people I've asked to sit here with me today have not earned their place here by mourning. They've earned it by working in Lilongwe, in Washington, in Ministry of Health offices, in hospital wards, in policy corridors, and in philanthropic boardrooms. And by refusing for a long, long time before this moment, the premise that global health belongs to its donors rather than to the people it claims to serve. So the question we're going to sit with today is, where are we? And what will it take to build a global health architecture that is genuinely accountable to the communities it claims to serve? An architecture where the people who survived colonialism, structural adjustment, and decades of donor-directed solutions are not just the beneficiaries, but architects and leaders. The collapse of familiar funding structures is a crisis. It is also an exposure. And our task today is to ask whether we have the courage to use this moment not to rebuild what wasn't working, but to start building what actually can. And so these group of panelists, I have 3 panelists with me that are phenomenal that I'll introduce briefly because I think their accolades are too much to list, but kind of their relevance to this conversation today. So I wanted to introduce Brown David Congo. Brown is a non-communicable disease and mental health director at Partners in Health in Malawi and a former HEAL Global Health Fellow. He was born and raised in northern Malawi, and the geographic detail matters because Brown is a leader in global health whose own life maps onto the geography of the patients he serves. He leads the programs that have, against enormous odds, built mental health and chronic disease care into a rural health system most of the world has often written off. And he is here to speak from the ground up about what it means to lead a system through an external shock when the expertise, the commitments, and the solutions have always lived inside the community itself. The next panelist is Nidhi Bori. Nidhi is the director for Exemplars in Global Health at the Gates Foundation. Before that, she served as the Deputy Assistant Administrator for Global Health at USAID, which meant she has community continuity across two institutional worlds we need to hear from at this moment, the US government and large-scale philanthropy. Nidhi has spent close to 2 decades in global development, and she is here to speak to a question that has become unavoidable. What does responsible stewardship look like from philanthropy when the traditional aid architecture is fracturing? And what does it mean in practice to invest in country-owned solutions rather than donor-directed ones? And our last panelist is Vincent Lin. Vincent is the Associate Director of Health Policy and Advocacy at Partners in Health. He wrote several books with the late great Paul Farmer. He's my go-to in terms of understanding global health policy. He has a strong moral center and an incredible policy mind. He has been an advocate for GME funding in Native communities in this country, as well as legislation across the board on global health workforce and funding. And so Vincent is here to map the federal terrain for us, where the State Department bilateral agreements currently stand, what the cuts to USAID and PEPFAR look like up close, and what advocates are fighting to protect and reimagine. So Brown, Nidhi, Vincent, thank you for being here. And so we'll have a couple rounds of questions, and then obviously want to hear from a lot of you that are listening on. So we'll have definitely some time for question and answers. So I'll start with the current rupture, sending it over to Vincent. Can you give us a 10,000-foot view of what we are seeing by the United States in global health funding and policy following the destruction of USAID and the current status of PEPFAR? That's a big question, but a 10,000-foot view. Vincent.
Sure, yeah, and we can maybe dig in further subsequent questions. So there's U.S. contributions to global health through the aid system, separate from, as you mentioned, all the debt that is extracted by U.S. banks and through sovereign bonds, is really 10 to 12 billion a year through USAID, State Department, CDC, and also through multilaterals. So maybe let's just start with the multilaterals. So right now, Gavi is owed 600 million in overdue appropriations from Congress. It's FY25 and 26 money that RFK, the HHS secretary, has been holding up. And this morning, Senator Shaheen, in the hearing with Secretary Rubio, pressed him to release these funds. So that's one bucket of funding that hasn't yet gone up. Another multilateral fund that we've heard about a lot in the last few weeks, in particular around the Ebola outbreak, is the US no longer contributing to the WHO through voluntary or assessed contributions, which over the last 10 years or so maybe averaged to around 400 or 500 million a year. So the WHO has dramatically cut staff, fired thousands of staff, downsized more than 20% as a function of that. The third multilateral channel, the Global Fund to fight AIDS, TB, and malaria, the US never completed their Grant Cycle 7 pledge, cutting funding across countries by more than 10%. The replenishment aid pledge, the State Department committed to 4.6 billion over the next 3-year cycle for Grant Cycle 8, but then promptly reneged on that commitment, saying that it would be actually over 4 years. And this morning, again, Marco Rubio saying, now we've hit the cap for the Global Fund. That's actually incorrect because there's $2.5 billion right now that Congress has appropriated in FY25 and FY26 that has not been sent out the door for the Global Fund. So on the multilateral front, the US has contracted dramatically its contributions across Gavi, the WHO, and the Global Fund. When it comes to the bilateral portfolio, that has changed, massively. Um,
Can you just say
we
like what that is, Vincent, the
Yeah,
bi
absolutely. So the bilateral portfolio consists of the flagship PEPFAR President's Emergency Plan for AIDS Relief HIV program, more than 4 billion in funding per year. That was historically implemented about 40% by CDC and 60% by USAID. Of course, USAID, many of those programs closed. Some of that money is still running through implementers. And the CDC program, that 40% has also been cut down, even if many of those programs have survived. So PEPFAR itself, the interagency program, looks completely different than it used to and is slated to undergo massive changes between now and the start of the next fiscal year, October 1st. And we can get back to that. The other components of the bilateral programs included the President's Malaria Initiative, PMI, malaria funding close to a billion a year, maternal and child health funding close to a billion a year, tuberculosis funding bilaterally about 400 million a year across 25 priority countries. There's also money for nutrition programs under the Global Health Bureau. And then when it comes to outbreak response, a lot of that funding was channeled through the humanitarian Bureau of Humanitarian Response at USAID. So there's also WASH funding, nutrition funding that came through other channels other than what on paper is called, global health money from Congress. So all of that bilateral funding is now really up in the air because the US has, in September, the State Department put forward this America First Global Health Strategy, laying out a plan to do these bilateral negotiations across more than 50 countries. As of today, 32 of those MOUs have been signed, and the Wall Street Journal yesterday just published a piece describing how negotiations have broken down across several countries. So Ghana, Zimbabwe, Zambia, where the New York Times reported on the linkage between access to critical minerals and PEPFAR funds directly in that compact negotiation. Those are heavily contested MOUs that have not come to fruition, and it's very unclear what will happen to these portfolios that are, hundreds of millions of dollars per year in health aid in particular. Where the MOUs have been signed, there is a promise, a potential for greater government-to-government support on budget direct support through ministries of finance and through the treasuries of countries. That is not a blanket policy, even if it appears to be in the America First Global Health Strategy. As we look at the development of implementation plans, which is the second phase of this bilateral negotiation, the actual implementation plans vary dramatically. Some countries, there's no G2G. Some countries, G2G is put out 3-4 years from today. And other countries, specifically Kenya and Uganda, seem to be looking at G2G that could start as early as July 1st, although they will need to go through the hurdle of having Congress actually approve using money through that channel, those mechanisms. So I think there's a lot coming in the next few months as to how these MOUs are actually rolling out across countries. And overall, if we take a look at the levels of spending in the MOUs very explicitly through the America First Global Health Strategy put countries on this, quote, path to self-reliance, meaning the US is cutting funding. Transition is not really the best word. It's cuts to funding. It's a sunsetting of the PEPFAR program and other bilateral funding as well. So some countries like the DRC, in year 5, their funding sits at, a 60% cut compared to today. Rwanda overall gets cut down 70% in their funding. Malawi, 35%, Burundi, 55%. These are huge cuts to assistance, even as Congress continues to flat fund these programs. So this is a choice that the State Department is making to not spend monies through these bilateral compacts. Over 5 years, we're looking at $12 billion in appropriations that won't be spent in the ways that they have been in the past. If we look at the last 5 years versus the next 5 years. So if Congress keeps funding those programs, then there will be a lot of money sitting in Treasury in an account tagged for health assistance that's just not been used. So maybe I'll stop there and we can talk a little bit more later about government to government, the complications, how countries are looking to do co-financing, like through new co-pays, taking out new debt, as you mentioned, and as we know in Malawi already, that debt expenditures just to service debt are 4 times the domestic health budget. How that comes up against wage bill constraints when you try to hire more people onto the public wage, right? We're already having situations where you can't hire nurses onto the public wage because of these wage bill caps with loans. We can get into all that later, but I just wanted to give that broad overview of where we're at with the multilateral and bilateral spending.
Thank you, Vincent. I mean, that's a amazing overview and obviously like very disturbing overview of what's already been cut and stands to be cut. I wanted to turn now to Brown. You mentioned Malawi, kind of servicing the level of debt compared to health expenditure. And, Brown is, he's potentially off video because his internet is not phenomenal in Malawi. But I wanted to ask you, Brown, when the funding interruption hit, what was the first thing that broke in your health system, and what is the first thing that held? And can you give us a picture of what has changed for patients, staff in your hospital wards over the last 12 months? Brown,
Thank you so much, Siri. I hope you can hear me. I was able to follow through, but even Vincent was breaking a bit, but thank you so much. Um, so I should start by acknowledging that when the interruption happened, the impact was huge and was actually manifested in most of the sectors, not just in the healthcare sector, but specifically in the healthcare sector. I would say that even if this was something that maybe the Global South was able to see that would happen at one point, the way it happened actually it was still abrupt in the nature. So one thing that we noted mostly was that the service delivery was the first part that was hit hard. And that's where we saw most of the impact because the operational systems for us to take the services to the patient, the communities was affected. And one part that we saw the most, and actually also to Vincent's point, was there are service areas that were mostly funded by the donor community and the US government being one of the largest funders of some of the service areas. And those are the areas where we saw most of the impact with USAID and PEPFAR reducing the support or freezing some of the support completely in some of the work areas. However, I should also mention that at that point, we still saw that the government was able to stand out and respond to the shock. So one thing that we saw, what I saw, I would say that it was more of like putting the public sector resiliency in a test. Like how would it respond in such scenarios? Because what we noted that is in the midst of the trouble, in the midst of the constrained resources, services were continued. We also saw that the patients and the communities still stayed, kept the trust in the system, in the services that they're getting from the community and even in the facilities. Even if we noted that the systems and structures had changed abruptly with those changes. Speaking into some of the specific areas, I would say that when I look at it from the angle of the patient, I think this brought some uncertainty, especially when you think of in the infectious disease areas like HIV, TB, malaria, because these are heavily funded by donor aid and most of it from the US government. I think the communities were worried. We could see the worries in terms of where do we get the medicines. And I think it brought up some of the memories of the early eras of HIV when we lost a lot of people in the global south. And I think so that's one part that I would say. And then the other part is there was
So,
also a
Brown, sorry to interrupt, the piece of bringing up kind of for patients the early HIV time, like not access to having medicines and kind of just interruptions in care and a level of does that correlate with like more distrust in the system? How did that play out for what you're talking about, infectious disease patients specifically?
Yeah, so I would say we still saw that the communities and patients were still flocking and coming to seek for the services. Even if the message was sent out globally that there was a huge cut in terms of the services, but the government through the Ministry of Health also was very quick in terms of sending out the alternative message and bringing hope and to the community of the patients that we still had some of the supplies in stock that we are able to run through at least for some months while the government was looking into how best to actually resolve the shock that was hit by this cut. So we did not see much in terms of the distrust because I think the government was quick also to respond, especially to engage the communities through the Ministry of Health.
Awesome. Thank you, Brown. I think that perspective of what we're seeing from what Vincent kind of outlined. Now I wanted to turn to Nidhi. You've sat inside both the U.S. government and philanthropy. So how do you read this moment in global health? What are the institutional players getting right about addressing the rupture, and what are they still getting wrong?
Thanks, Sri. I think particularly reflecting on Vincent and Brown's comments, there's no doubt that the withdrawal of funding from government donors, of course, we're talking a lot about what was USAID, it was abrupt, right? And so it's not just that they're currently sunsetting and maybe transitioning more to models of assistance that are more aligned with what they deem as national interests, but it's the lack of a glide path that I think was so disruptive in particularly last year. And we're still seeing that ripple a year and a half out, from almost a year and a half out from when some of these cuts initially started. And there's no doubt there's been backsliding. I'm sure many on the line have seen, hard data and modeling that's come out, published in the Lancet and other sources that really is giving concrete numbers to the way that these reductions and changes in funding are impacting people, all around the world. So I think the questions that have really surfaced are on one side, there is the need to mitigate the level and extent of that backsliding. And in parallel, the question is, how are we rebuilding a system in a way that doesn't create the same risks in the way that the system had been operating to date? In my opinion, the foreign aid architecture was fragmented before these cuts happened. And I think that not to by any means dismiss the way and how some of these shifts in funding have happened, but we really have no chance, I think, way forward without looking clearly at what wasn't working and making sure that we're not incorporating what didn't work, into future structures. And in that way, I think we kind of have to embrace this time as an opportunity to reset a global system. And then that comes down to regional systems and national health systems in a way that works for how countries want to lead and what is really centered around needs for communities. I think the people who are getting it right now are the ones that have the clarity that we have to think differently. And the ask and push should not be to rebuild institutions and structures in the way that they were, but to actually shift and talk more about what are priorities that governments have identified for their populations. What are global targets we want to reach as a global community, reducing certain levels of morbidity and mortality from a range of causes, and not give up on the fact that we still have to reach those. The question is how we do that has to change. And so I think that's where when we see government donors shifting, whether it's the walking back, the sunsetting, the changing the priorities of what they want to put funds towards, philanthropy, in my opinion, is actually doubling down on doing more of what we know works, and I think has been energized as a community to figure out even more so what are some of the effective ways to leverage tools and innovations and proven strategies working with governments And the model of philanthropy has always been fundamentally different than the model of governments. I mean, I'll say in the time that I was at USAID, we appropriated 10 billion a year in global health. There was a tremendous amount of work that we did, in partnership with countries around the world. And some programs had fresher approaches and some had approaches that had been longstanding and I think probably were due for a bit of an update. And philanthropy's approach has been always fundamentally different in that there's a higher risk tolerance, particularly to support innovation and kind of identify how big bets could actually be game changers in saving lives and reducing illness, et cetera, across the world. And the challenge we have now is that what used to happen is that philanthropy could drive innovation and then kind of hand off or kind of partner with government donors who may have taken more of the scaling investments. And those scaling investments aren't necessarily happening because of the shifts that we've seen with government funding. And that I think presents obviously a challenge, but really an opportunity then of how do we continue to double down on centering and working just directly alongside governments in the way that they're budgeting for public health, in the way that partners who are still putting in resources to support governments may be then considering different types of investments to reflect some of the things that we can figure out work.
Got it. Yeah, I think that is helpful, a helpful frame of, and it kind of bridges us to kind of the next line of questioning that I had for you three around we were talking about the rupture that I think Vincent laid out so well, and kind of Brown talked about what it looks like on the ground, and then Nidhi, you speaking about like how philanthropy is trying to shift in this moment, and some of the challenges given that you can't pass off to government owned programs in the same way. So, I wanted to talk a little bit about kind of the building or, the Lusaka agenda that kind of came out in 2023, which is a framework it's a global health framework to try to restructure how international donors fund healthcare in low and middle income countries. And it is the aim in that conversation in 2023 was to shift power away from siloed international donors to empowering national governments to lead, coordinate, and integrate donor investments into a sustainable, domestically financed primary health system. So some of the goals that came out of that conversation was to strengthen primary care, to promote sustainable domestic financing, and then asking like major entities like the Global Fund and Gavi to align their funding cycles so it's easier for countries to access those funds, and then also to coordinate research and manufacturing. So starting kind of back to you, Nidhi, in terms of as you kind of are new to the Gates Foundation and kind of learning the philanthropy world, have you seen philanthropy start to pivot into kind of like what it should look like in a Lusaka aligned world, or is there mostly like, there's so many gaps that Vincent named that we're kind of trying to just backfill to some extent? Obviously, you can't match what the U.S. government did and other countries that are stepping back have done. But just speaking about the Lusaka agenda and kind of how you've seen philanthropy either shift or change in this moment.
Yeah, I think so. The Gates Foundation, and I think this is true for other philanthropies too, have had an approach historically that remains true now, which is more of working alongside governments. So not kind of doing, earmarked funds that go in the way that bilateral government funders have typically had the model. And what that approach, the difference of that approach, I think, is what's presenting tremendous opportunity right now. So our engagement is to really come in as a thought partner with governments, figuring out what are their priorities, what are the biggest needs and gaps, but more so, what are some of the options and solutions that can address those country identified needs. And for my program, Exemplars in Global Health, the way we very specifically do that is we actually fund research institutions around the world, many of which who are representative of the countries or regions that are exploring some of these questions, to really drill down on figuring out, with whatever expenditure is available, how do you get the most bang for your buck? So what are concrete proven strategies, whether those are in what we traditionally call the vertical disease programs or some of the kind of cross-cutting health systems, primary healthcare interventions? And that I think is particularly useful right now because one of the understandable responses to the rapid decrease of funding at a country level is this push to look more at a primary healthcare model, which many countries have identified for decades as the way that they wanted to move things forward. And actually, the way that funding came in precluded their ability to really drive more of that model forward. So now where I think the opportunity is, and what we do at Exemplars, is really try to identify what are some of those best practices to actually scale up primary healthcare delivery, whether it's subnationally or nationally, and how can other countries learn from each other and how to do that. So I think that's one example concretely of where I see philanthropy leaning just more intensely into that kind of space to bring along that thought partnership, but figuring out how we move from just saying, yes, we understand these are priorities, but the how countries can actually deliver on those. And so our engagement is on that how. It's figuring out what are those concrete steps, how do you get there? You know, where is it that a country wants to go? How do they get there? What are the models they can learn from and the tools that they also could embrace? And then the second thing I would say is, I do think that one of the real things that's standing out to me in the philanthropic world is looking at the long game. So wanting to make sure that as we work alongside national governments, that approaches are not a band-aid, that they're really evidence-based and driven to think at how we can achieve some of these targets that are being set out, whether it's by a government or kind of global targets we have by 2030, you know, on a global agenda, and making sure that we're looking concretely at what's needed for the sustainability of components of systems. That's rebuilding and ensuring that we don't have gaps in things like data systems, you know, demographic health surveys, when that went down, catastrophic immediate impacts. And so these are types of components of health systems that are critical, not just at a global level, but most importantly at a national and a subnational level, to ensure that we have ways forward to actually measure progress and also very quickly see when there is backsliding and figure out why that backsliding is happening. And so the general take I have in philanthropy is that the energy is around ensuring using philanthropic capital for risk taking to find some of those solutions, not to be a replacement necessarily of just the way that things were funded before.
Got it. Yeah, thank you, Nidhi. Brown, you know, I think speaking to what Nidhi's talking about in terms of country priorities, and you know, I think this idea of country owned is a phrase that gets used a lot. And so wanted to hear from kind of inside of Malawi, inside the system. How does it feel, you know, and something to be truly country owned, and what conditions need to be in place to have that be, you know, less of a slogan and more kind of a reality? And how are you seeing that in your work?
Yeah, thank you so much, Sid, and thank you so much. I would start by saying, to agree with you, that sometimes this country owned or country ownership or national ownership can just be rhetorical, you know, in nature, but not necessarily maybe something that we actually see at the moment on the ground. Because as you put it, the Lusaka agenda came into place like in 2023, so years have passed. And it's an agenda that pushes for the right thing. And I think it came at the right time when we actually saw that most of the systems in Malawi and as it is in the other global south, they still remain fragmented, and fragmented not just because of the internal forces, but also because of the impact of the external push. Because even as Nidhi was sharing, we are still extensively donor dependent in terms of funding. And usually, because those who bring the resources, sometimes actually they end up being the ones to set the priorities on how you actually use those resources. And then you end up actually missing out on how things should look like So we don't see much of the alignment, for example, even after 2023 up to now, we still see some slots or some spots where things are still parallel, systems are still, NGOs are still running like parallel systems, and donors driving their own agenda, donors driving their own priorities, donors also checking for their own metrics, maybe different from what the country would want to actually go for. For me, I think country owned or country ownership um, should be something that, first of all, we need to not just transition the power or transition the authority to the national governments, but actually there should also be an element of transfer of responsibilities. Like Nidhi was sharing, to say this has to be um, viewed not just in isolation, but globally together with the other objectives that the SAC agenda is pushing. For example, strengthening of the primary care systems, and then also driving domestic funding for resources to actually start pushing the national government to take up responsibility and accountability for the health of the people, and not necessarily just only push on the prioritization when you don't actually maybe co-contribute into the funding. Because apparently what we need to be start seeing is the nations or the countries should be having like a plan. So we need to see like there should be one national plan, and then one budget, and then also one monitoring tool or monitoring framework, so that whenever we have resources coming from external funders, these are supposed to be pushing that agenda, not necessarily coming in with parallel structures. So far, I would say we have started seeing some of that shift in some spaces, maybe in Malawi and maybe in some of the countries too in the global south, where we actually see like services harmonized. We see elements of integration being spearheaded. We are seeing the governments now pushing for domestic resource mobilization. Malawi, one of that, and then we have started seeing where the national government, because of the shock that actually we saw, start pushing that systems or services should be built on the foundation of government and should be run by the providers that are actually within the system of the national government. For example, I would say that Malawi, though still in the process, when you look at the health sector strategy plan number 3 for Malawi, which is actually the framework or the strategy that we are using at the moment, and it's going to run up to 2030. The thematic area is the same, like in the SAC agenda: one plan, one budget, one monitoring framework. But I think what we want to start seeing is how do we translate that into practice, because sometimes it could just remain rhetorical that the countries are empowered, they have their own plan, but definitely maybe it's not something that we see happening on the ground. So I think what we want to see now is how do we move from this just being a slogan into something that we see in practice, that the nations are really leading. And that, for me, has to come with responsibility and accountability from the national government, especially when it comes to domestic funding for the health systems in the global south, including Malawi. Thank you.
Thank you so much, Brown. I think that was very clear and well said. And I think you're right that this implementation gap that we often see, sometimes the national plans written on documents are beautiful and coherent, and there's a right to health, and that's so different than what we experience as we take care of patients. We're at 41. I was going to ask one more question of Vincent, and we have a bunch of questions in the chat from the audience that we'll turn to after this question. But Vincent, hearing what Nidhi and Brown are talking about, you sit on the policy realm, and so what are policy advocates fighting to protect at this moment, and what are you all fighting to reimagine? And who is doing the reimagining well, and how might we polish the old model of how we've been thinking about global health policy and funding?
Yeah, I think so much of our work these days is actually trying to prevent destruction of working systems. So, for example, there's new guidance out about the role of CDC PEPFAR, and we could see soon in the next few months a collapse of a lot of the CDC PEPFAR programs, maybe half of them, with new state guidance that was leaked in May. There is a term that's being used in the State Department called creative destruction. And what we see is like a lot of destruction and then later post hoc rationalization, a lot of creativity to talk about, what comes out of that. And it's a commitment to ending programs before you figure out the strategy for continuity. That's the case with the CDC PEPFAR components because those programs don't have no replacement mechanisms on the table right now in time on the same timelines. There's no overlap. There's actually nothing after the cliff. We see that with supply chain, right? There's discussion about the global health supply chain, PSM contracts, about $1 billion a year. There are hard end dates without plans to transition the functions beyond procurement itself. So procurement moving to Wambo could streamline things in country, although they're not apples to apples. Commodities ran 4 task orders, including maternal and child health, family planning, reproductive health, commodities, and Wamba's received some initial tranche of 260 million for maybe just procurement specifically. At least that's what we can see in the USA spending data. So there's no plan for delivery, warehousing, last mile distribution, forecasting, all the other aspects that are critical to the supply chains for both HIV and malaria commodities in what's been funded by the US government. And so there's a lot of our time and energy is focused actually on making these forced transitions slightly better in terms of continuity of services. And as there's been a lot of rhetoric about, rhetoric versus reality, right? With America First Global Health Strategy, the rhetoric of government to government, and then the reality of that maybe playing out in a handful of countries, other countries not getting any funding at all anymore, like in Zimbabwe or South Africa, and other countries where maybe GDG is many years away, years of risk assessments and evaluations before they even get to a discussion of the ministries of health controlling and having a seat, really being in the driver's seat when it comes to the external funding from the US government. I think so much of the coverage of the MOUs, and you can hear it in the talking points, is even this morning in the hearings, is around sovereignty, around like MOUs equal sovereignty or decolonization. And you'll hear it from ambassadors, you hear it in written and oral statements, and that's so much conflated with some idea of health equity or health access. You can be a fully sovereign, decolonized nation like North Korea, spend all your money on services for a handful of people, and leave, most vulnerable citizens in the lurch. Accountability, you could define it as what the heads of state are saying about this process. They will celebrate US funding coming directly to them, even if at 50% cuts. But that's not the view from the bedside, right, Shri? That's not the view from the ground. That's not how maybe patients or physicians would often define accountability, like who's accountable for what. Let me just look at the sovereignty on decisions about healthcare services and access in the United States. With Medicaid expansion highly variable across states, you can say that's, states are asserting their sovereign right to determine who has access to these federal Medicaid dollars, or in the post-Roe landscape, what is access to services state by state. But that doesn't mean that there's no equivalence to health equity, right? So I think sometimes those two terms in the last few months have been conflated, and I think it's really important to understand where those two things are related or synergistic or actually oppositional, with some countries that are highly against key populations and services for key populations. Like that's something that PEPFAR, in some ways with external financing, protected in some cases against, sovereign national governments. I think one of the other things we're seeing is around this conversation of domestic resource mobilization is there are a lot of unintended consequences when the US government is asking countries to increase their domestic financing through these bilateral agreements. Like former staffers inside the State Department's Global Health Security and Diplomacy Bureau have said there's been very little consideration of the actual ability of countries to reach these co-financing commitments, even if they're penalized for not meeting them. Former staff have said it's not clear, there's some magical thinking going on amongst leadership that countries will suddenly be able to mobilize domestically hundreds of millions of dollars over the course of 5 years to replace the health financing that's being pulled out. And where countries are looking to do that, it could very negatively affect patients in these same area of services. So, for example, you pull money out of an NCD's program to fund an HIV program that the US government used to fund in order to meet co-financing requirements, like within that sector, right? You reduce money from a primary care program to finance something specifically on TB to match the US money. You look, there are countries actively looking at introducing co-pays at the point of service or co-pays for drugs at pharmacies where the US government used to pay for those services, which means not only will people not show up to clinic, like not only will people not show up to clinic because they're not willing to pay to see a doctor or not able to pay to see a doctor, they also won't be able to get their drugs at the pharmacy because they're not able to pay copay on the drugs. So a colleague of ours once wrote a book that initially was titled Selling Medicines to Starving People. Like the thesis is you can't, that's not a functional way. When we talk about structural adjustment and some of the lessons learned, it's like we're turning the clock back in some of these areas when we're asking countries to, when we as the United States are asking very low-income countries, very impoverished countries to increase financing in that ecosystem or environment. It is also true that the US banks, in their lobbying in legislation in New York state regulation, for example, have given themselves far more power to negotiate very high interest rates from low-income countries and actually take advantage of the sovereign debt ecosystem to make money, right? These vulture funds that purposefully buy debt and sue on it to get huge payouts in Argentina or otherwise. And so there are efforts to change that legislation in London, in New York. But right now, if countries that are highly indebted want to borrow new money to pay for these services, they might be paying 2, 3 times the interest rates as the United States would, for example. So it is really difficult. And I would say it really differs country by country as to how ministries of finance are thinking through DRM to meet these like MOU co-financing requirements. And a lot of that will be worked out in the next year. But I think there are a lot of potentials for unintended consequences, even within the health sector, like creating new gaps in other places as a result of mandating this co-financing.
Thank you, Vincent. I think that's that's very clear. And I think the themes that you're pulling on, have been in this conversation, like the level of gap between rhetoric and implementation, and some of these simplistic ways of thinking about like sovereignty doesn't always include health equity, and we know for a long time that point of care payments just really decrease access. And so if it matters a lot of these details, and I feel like we can, and that's why it's so important to have all of us kind of paying close attention to how this plays out, because I think not matching the reality in so many places. And so we're getting, to the last few minutes, and I wanted to hear from some of the folks, the folks that are listening on, if there's some questions that people wanted to raise to you all. So Kia, is there some questions from some of the audience?
Yes, there are. Thanks, Sri. And yeah, thank you again, panelists, for that great discussion. I have a question here, and it is about the funding cuts. So, with all of the cuts in funding from the United States, has China picked up some of the funding to continue these critical programs? If I'll see if Vincent or Needy, if you have any insight onto those.
Minimal to none is my understanding.
I have a similar understanding. I think there have been verbal commitments. I don't think there has been concrete things to point to of funding actually coming to countries.
China's investments tend to focus on infrastructure and education a lot more than they do in the health sector.
Thank you. And then I have another question here. This one's for Needy. So you mentioned um, wanting to have in philanthropy shifting from, band-aid solutions to more long-term solutions in terms of global health, filling gaps, rebuilding, and whatnot. Do you have an example or examples that either you've been a part of or you've seen that has been a successful start to or long-term solution?
Yeah, it's a great question. So, one area that my team actually spends a lot of time thinking about is primary healthcare. And so we've done kind of effectively what's implementation research, right? As we support organizations that might be testing different aspects of service delivery, but particularly kind of how to integrate new tools that can expand reach of the health system. And then how you take that evidence and essentially replicate it. So, what's interesting right now is there's some very promising work in Rwanda around leveraging AI enabled tools to actually expand primary healthcare access. And AI enabled tools, there's a lot of buzz in the global health community around leveraging AI. And I think most important for us is to figure out what actually works, and equally important is what doesn't, and when it might not be helpful to a health system in a community, but to really ensure it's clear on what can be done. And Rwanda will be the first country in the world to actually scale some of these tools across every primary healthcare facility in the country. And that I think is going to provide a lot of learning into how countries with similar contexts, subnational contexts, can look at innovations as a way to accelerate reaching certain targets, addressing inequities and access to healthcare, kind of the more positive aspects. But also where it's not going to help us, right? I think, again, equally important to kind of see that clear-eyed. So it's an example right now of, I think, where philanthropy is able to take its investment in innovation, but be very focused on, does innovation actually help you reach health outcomes in an accelerated, comprehensive manner that is very human-centered, obviously safe, importantly, and so that's, I think, one great example of where we're seeing the ability to connect philanthropy's investment to the potential for scale. And it's fully designed with the Ministry of Health. So it's really as they have determined their priorities and using those resources to support what they want to invest in.
Yeah, definitely. Each country, of course, works differently, but it's exciting to hear, the beginnings of trying out innovations and seeing if it can be further scaled. I want to send it over back to Shri to have a closing question for our panelists.
Yeah, I think we're getting close to time. Thank you so much. I think you all have a world of knowledge, and I think the specificity of paying attention to what is going on right now is so crucial. And I think kind of the things that Vincent laid out, I think we can't be naive that to anchor in kind of hope and optimism at this moment, because there's so many things that are in rupture and are being actively destroyed and broken. But to end this kind of on a potentially hopeful note is like, what are you all either anchoring to or pointing to that is giving you some optimism or hope in this moment? Either organizations, policies that have kind of come through that are surprising, or approaches that feel hopeful in this moment of rupture. So we'll just do rapid fire. Whoever wants to go first, and then we'll go down the line.
I'm happy to go first. I think one thing that I've been really happy to see in the last couple years, but really accelerated in the last year and a half, is that I think the world has finally woken up to the reality of the importance of investing in community health workers who have long carried the way that most people in the world get health services. My family has depended on community health workers, but now are being asked to do a lot more, given this push for integration, the lack of being able to perhaps provide specialized services in a range of parts of the world. And I think with at least that awareness and commitment, the question is really, how do you go beyond the lip service of a political commitment to supporting a population of the health workforce by which most of the world gets services, and really drill down in terms of meaningful ways to support that cadre to deliver services, since they're going to continue to be asked to do more.
Thanks, Tindy. Vincent?
In November, I was in Sierra Leone, very rural Sierra Leone, Kono. Maybe some of you guys have been there. And a place where extraction has existed for hundreds of years with the diamond mines and very little to show for it. Thinking about the Ebola outbreak happening now and where West Africa was 10 years ago, and the new opening of this maternal center of excellence, a teaching hospital with 120 beds and NICU, 3 operating rooms, autoclaves. It used to be a death trap, after the Civil War 20 years ago. And then during Ebola, there was very little on offer clinically. Paul lamented the very high case fatality rates at this hospital and other facilities. And I think as we look at what's happening in the DRC, I've hopes that we can emerge from that and have things like the MCO there 10 years later, because people will start paying attention to these, this as an acute on chronic situation, that, more people die from the rest of the causes than Ebola itself. So I think that really gave me hope, being in that hospital in Sierra Leone and see, well, like so many hundreds of babies are going to be born healthy. Moms are going to get C-sections here in a place where it used to be literally called a death trap, that public hospital. So we can do a lot when we keep at these long-term problems over time.
Thanks so much, Vincent. Brown, we'll end with you.
Yeah, thank you. I think for me, I would end with a saying which says that if something is kept inside, it bends, but if something is kept outside, it breaks. I think this just reminds me that we need to build the systems within the structures that still already exist, because otherwise, if you come up with outside that, it doesn't survive. It disappears in a time of shock. So this time has taught me that whatever system we are building, we need to build around that. And another message that I'm taking home, and I think I'm clinging to, is even in the midst of constraints, even in the midst of trouble, and even in the midst of the abrupt shock, it is possible for us to provide care and continue serving the communities and the patient with a human face, but also in a dignified manner. Thank you.
Thank you so much, Brown. And thank you to the panelists. I think what you all said, I think one of the principles of HEAL, and I think Paul Farmer used to talk about a lot, is this idea of relentless incrementalism, where you show up and these health systems can get stronger over time. And those of us that have been doing this work for a long time, I've worked in rural Burundi and Sierra Leone and Liberia, and some of the infrastructure and the delivery of care have gotten so much better over the last 20 years. And so kind of keeping our heads down to those realities, as so many of the systems have been actively kind of maliciously ruptured in at the same time. So thank you all for joining. And if this recording will kind of be sent out, and there was a lot of folks that also kind of signed up and wanted the recording. So we totally appreciate your time, and thank you for being here.